Welcome, everyone. We will just wait a moment to allow folks to enter from the waiting room. My name is Dr. Elizabeth Watson. I'm a UVM Cancer Center radiologist and assistant professor at the UVM Lerner College of Medicine, as well as a co-chair for this year's annual Women's Health and Cancer Conference. Joining me to welcome you and introduce the day is my co-chair, Michelle Macheski, a physician assistant in the high-risk breast clinic at the UVM Cancer Center.
We are so excited to be here with you this morning. We had hoped that we could meet with you in person, of course, but we are so grateful to our amazing speakers, planning committee, and all of you for making this virtual experience possible. Importantly, we want to thank our presenting sponsor, the Victoria Buffum Fund at the UVM Cancer Center, for their tremendous support, as well as the Eleanor B. Daniels Fund at the UVM Cancer Center, and the very many of you who donated when you registered for today's event. Philanthropy helps us to continue to create free, high-quality community education and support programming. Thank you.
As a cancer center, we are committed to community education because we know it empowers patients, providers, and the public to better health outcomes. This event is unique in that we are all here learning together and from each other. For a successful day, we want to provide a few housekeeping tips. Despite having more than a year of experience with Zoom, it is always possible that the technology may not go as planned, and that's okay. We will make sure all content is available after the event on the Cancer Center website. Please participate. You will be able to submit questions through the Q&A function in Zoom at any point during a session. Your thoughtful questions enrich learning. Speakers will do their best to get as many questions answered as possible during the live Q&A portion of their sessions. Lastly, we want to recognize the many community resources in our region that with the UVM Cancer Center are here to support and care for our cancer community. You'll find many of them in our virtual exhibit hall this year, also available on our event website. We hope you enjoy the day. Thank you again for joining us.
I'm pleased to introduce Dr. Rick Page, Dean of the Lerner College of Medicine at the University of Vermont. Dean Page received his medical degree at the Duke University and was previously the head of the Division of Cardiology at the University of Washington School of Medicine in Seattle, Washington, and the chair of the Department of Medicine at the University of Wisconsin School of Medicine and Public Health. In October 2018, Dean Page became the 18th Dean of the Lerner College of Medicine, and we are so grateful for his leadership and support for the work of the UVM Cancer Center. Welcome, Dean Page.
Welcome to everyone joining live or online for this 24th annual Women's Health and Cancer Conference. Of course, I wish we could all join together in person, just as this conference did for 22 years in a row. And I hope for the best at the silver anniversary next year. But for this year, to stay safe and stay informed, I'm glad we have Zoom to enable us to join together in a meaningful and enriching way. This is always a special event in that caregivers and patients are brought together to share experiences and clinical information that will help each individual in their role. How can we better embody the concept of patient-centered care? This conference will update participants on several important and relevant topics, including research affecting breast and other cancers, the role of the immune system in cancer, and the use of complementary and integrative approaches to care. Now, COVID itself has had an undeniable impact on cancer patients and their providers. We're honored that Lerner faculty member and Vermont Commissioner of Health, Dr. Mark Levine, who has so ably led this state through this time of crisis, is joining this conference as a keynote presenter. I want to thank Dr. Watson and Michelle Macheski for your efforts as co-chairs of this important event. And I also want to thank the many individuals from the UVM Cancer Center and Office of Continuing Medical and Interprofessional Education for making this conference a reality. One of the most exciting elements of this year's conference for me is getting to formally introduce to this audience Dr. Randall Holcomb, the new director of the UVM Cancer Center and chief of the Division of Hematology and Oncology in the Department of Medicine. Dr. Holcomb brings to Vermont an exceptional breadth of experience as a clinical oncologist, educator, scientist, and leader in cancer research and care, including more than 3 decades in leadership roles at other cancer centers, most recently as director of the University of Hawaii Cancer Center, a National Cancer Institute designated center. He's held multiple national roles within the Association of American Cancer Institutes, where he's a member of the board of directors. He's also an associate editor for the Journal of Oncology Practice. Beyond his administrative experience, he has also led extensive translational research and has served as principal investigator for over 150 cancer trials, as well as several NIH-funded research project grants. His current research focuses on healthcare delivery science as a means to define and develop new approaches for the delivery of quality cancer care, as well as clinical investigations for patients with gastrointestinal cancers. Dr. Holcomb began his tenure here just 8 weeks ago, and he has hit the ground running. I know that in both his roles, he will have a major impact on our college, the UVM Health Network, and our entire region, in all facets of cancer care, education, and investigation. It's my honor to introduce Dr. Holcomb and to welcome all of the healthcare providers, patients, and family members who are taking part in this important conference. Welcome.
Thanks, Dean Page. It's an honor to join you. Since 1974, the University of Vermont Cancer Center clinicians and researchers have delivered compassionate and cutting-edge care, worked to advance cancer research, and uphold a commitment to our community. Our Women's Health and Cancer Conference is one example of this commitment. Today's sessions speak to health disparities, financial costs, and patient and provider support, because we are invested in identifying critical problems for the populations we serve and tailoring our programs to reduce the burden of cancer. Our next speaker, Dr. Mark Levine, is no stranger to this work. Dr. Levine has been Vermont's Commissioner of Health since 2017, during which time he has led Vermont in managing the coronavirus pandemic. Prior to becoming commissioner, Dr. Levine practiced general internal medicine with special interests in health promotion, disease prevention, screening, and clinical nutrition. This provided him with personal perspective on the challenges our healthcare system holds for physicians as well as patients. He is also a professor of medicine at the University of Vermont, and most recently the Associate Dean for Graduate Medical Education. He maintains his faculty appointment and continues to actively teach our University of Vermont students. Dr. Levine has gained a reputation as an outstanding teacher and educational innovator. This morning, we have the opportunity to learn from him as he offers his remarks on the impact of the coronavirus on cancer care. Welcome, Dr. Levine.
Thank you very much. Appreciate that introduction. I'm going to take a moment to share my screen. Hopefully everyone can see the slides at this point in time. I've been given a major charge here to talk about the Vermont Cancer Plan, specifically as COVID-19 has impacted it during this pandemic, and provide an update on COVID and specifically focus on vaccination issues, all in 10 minutes. So I will necessarily be a bit superficial with some of the information I provide, but I think you'll get the gist of it very easily. As people know, we do have a cancer plan. This is the 2025 cancer plan, which is being released as we speak. And I just want to focus on the core topic areas because we'll be spending a little time on this. First of all, health equity. Health equity, of course, is the fair and just opportunity to be healthy. And when we speak about equity, we're generally finding the populations that we historically have found do not have that same fair and just opportunity due to socioeconomic disadvantages, historical injustices, other types of systemic inequalities. I always like to look at it pictorially so you can see the difference between equality, where that mode of transportation is not exactly tailored to each individual's needs, versus equity, where we focused specifically on the individual and adapted the transportation to their needs. We're also going to be focusing on cancer prevention, cancer early detection, therapy, survivorship, and advanced care planning. All of the core areas we've had in previous cancer plans, but with refinement of the focus areas. My goal today is not to go through all of these focus areas for you, but to really show the impact of the pandemic on some of them. So here we have them clustered into one slide. So if we think about prevention, obviously this has been a very stressful time for the population at large. And we need to be cognizant of the fact that people deal with stresses in very many ways. And some of those ways are maladaptive and can lead down the road to very poor outcomes. And we all know substance misuse, tobacco, etc. We also know that people's attention to nutrition and physical activity suffered during the pandemic. We also know that in terms of early detection, there was a cadre of Americans who lost health insurance and did not have the same access to the usual preventive screenings, either because of insurance or because they could not connect with the healthcare system, or frankly, because they may have been afraid to connect with the healthcare system, not recognizing what we all recognized here in the end, that healthcare was one of the safest harbors to go to. COVID was not being transmitted from person to person in those settings. With regard to treatment, because of some of that fear, there were delays in treatment, but there were also delays due to the fact that the systems weren't working the way they always work during a stay home, stay safe part of the shutdown, if you will. And the access to insurance and ability to pay was also a factor. And then finally, there are a host of factors associated with survivorship that you can see on the slide. I'm going to just focus on each of these in a very narrow way in the ensuing work here. First of all, thinking about the impact on prevention, we know that if you weren't connecting with your clinical home, you weren't going to be able to benefit from hearing about what's available for tobacco cessation, discussing various strategies. And though these numbers aren't dramatically different, they're going in the wrong direction, which is really not what we wanted to see. The fact of the matter is, I did try early in the pandemic, while people had less to do because they were not traveling to work in other places, to emphasize the opportunity people had to focus on some of their behaviors and maybe improve upon them. But the reality is, stress and social isolation are very powerful opponents. As we know, we now have a vaccine that is cancer preventive, the HPV vaccine. Well, there was an interruption in young women and young men getting this vaccine because of the pandemic, with a dramatic decline in the rate of vaccination, as you can see. We also know that, as I mentioned earlier, lots of people in this country had disruptions in their insurance coverage, which had to impact all of the elements of the Vermont Cancer Plan. When we begin to look at exactly how the impact was on early detection, you see dramatic declines in things that we could measure over the period of time of the pandemic, which is mainly the utility and the usefulness of these screening tools, whether they be colorectal cancer screening tools, cervical cancer, etc. And you see uniformly across the slide marked declines in people accessing routine screening and a decline in the diagnoses of the kinds of cancer that some of the screening would have led to. Moving now to treatment, significant delays in care occurred during the pandemic with regard to cancer treatment. This eventuates obviously in decreased rates of the kinds of ectomies that would follow the consistent use of the surgical procedures that treat these. Now, some of these are because the patients weren't accessing this. Some of this is because clinicians weren't able to allow their patients to access this, and there's a whole host of other reasons. When we look at the impact on cancer care, there are projections that have been made to indicate 3,000 to 4,000 excess deaths may occur in areas related to breast, cervical, and colorectal cancer because of the pandemic alone. I'm now going to segue to how do we really help patients with cancer into the future. As you know, we're now in the booster phase of vaccination for COVID-19. However, we've just exited the phase that I would call the third shot phase, which is for the immunocompromised. For the mRNA vaccines, the third shot is considered just that, part of the primary immunization regime, not a booster itself. And it's specifically meant for people who are receiving active treatment for cancer, have organ transplant or stem cell transplant, or are on medications that obviously suppress your immune response, which includes most of the treatments for cancer. So very important that those in the audience who haven't availed themselves of this because they are a cancer patient or have a family member or friend who may not have availed themselves of this to get that third shot. Speaking of vaccination, we're close to 88% of the eligible Vermonters, meeting age 12 and above, to receive the COVID-19 vaccine, which is still a nation-leading number in the top 3. And we're now down to 67,000 of those Vermonters who are still eligible but haven't chosen to get vaccinated. We're eagerly looking forward to when our ages 5 to 11 children may be able to get vaccinated. Could be as early as the end of this month. We also now have about 78+% of the eligible Vermonters fully vaccinated, which is a very important statistic because one shot of an mRNA vaccine has proven to be not as effective and robust in managing the Delta strain, whereas 2 shots bring you right back up to that same level of protection against serious outcomes. Just to illustrate the power of vaccination once again, you'll see that if you just focus on the right side of the slide, well over a 4-fold difference in the rate of new cases in those unvaccinated versus vaccinated. This is a very powerful tool that we have. What have we learned from Delta? Not only is the risk of infection and illness, as I just showed, significantly decreased, but the most important thing is the 25-fold lower risk of hospitalization or death. Knowing that transmission can occur from both vaccinated and unvaccinated is the sort of cornerstone for why indoor masking continues to be recommended during the surge when there's high community transmission. And this is still humbling us in some ways because we thought we were through the pandemic, and the reality is we still are in it. No question about that. And we're still seeing high numbers of cases because even highly vaccinated communities have pockets of unvaccinated individuals. I'm going to close with just a few insights, if you will, my insights about life after Delta. Because we are going to get through this Delta surge, it's now predicted that the fall and winter won't be as bad as predicted. There won't be volatility and surge activity as we have been used to seeing in the last year and a half plus. Projections are that by March, the country may be under 10,000 cases a day. There'll be a huge number of people that now have not only vaccine-mediated immunity, but in addition to that, have succumbed to getting the virus, so they'll have natural immunity as well. In Vermont, we started at only about 2 or 3% before Delta. It will be well over 5% and higher after Delta. I don't know when, but sometime, maybe in 3 to 6 months, this will be an endemic disease, meaning it's always around. It's part of the background, like cold viruses, flu virus, etc. And that we'll be managing it much differently than we are in this time period when people are still gaining some community immunity. We will still have obligations to protect the most vulnerable, mostly with vaccine, but with other modalities of mitigation strategies as well. There will still be booster needs, but it's very unclear after this current booster phase when the next ones might be due. It could be years. The thing I fear the most is if the rest of our country doesn't start to attain the vaccination rates that the Northeast have, and more importantly, globally, the continent of Africa, most countries are between 2 and 15% uptake of the vaccine thus far. Not that they don't want it, it's just that they don't have it yet. So the faster we can get these hundreds of millions of doses from our country and other parts of the developed world to these needy countries, the better. We will always need to do surveillance testing in the future, and we'll have a whole variety of ways to do that. And will we be masking in future years? Not sure, because it's a cultural thing, not much of a medical thing. In Asia, it's very accepted. In the United States, I predict it would be less accepted. Finally, long COVID is the next epidemic, if you will. Unfortunately, we have the reality of many people who have gotten COVID. The statistics tell us perhaps 10 to 30% of them may have symptoms longer than 4 months later that could go on for a long time. We need to learn a lot more about this and manage it more effectively. We're already seeing, as I mentioned earlier, the effects of delayed healthcare and missed screenings. We don't know what the flu season's going to look like. Many feel it will be terrible because the flu was suppressed when we were all away from each other, and now we're much more congregating together. We're seeing RSV and other respiratory viruses already in higher numbers. But the only reassuring thing is that Australia did not have a significant flu season this year, 2 in a row. They did have some lockdowns off and on, but we'll see if we can replicate their experience. We have a dearth of antiviral therapeutics, especially for this virus, though Merck just came out with some news today. We'll see what that turns into. We have a significant PTSD aspect to both the healthcare and public health workforces, which we need to help them actively manage and learn how to prevent further damage from. And our population's mental health is not healthy right now. And we're already seeing the impacts of that with some of the more severe aspects like opioid overdoses and deaths from that, but just in rate of use of these substances as well at all age levels. And then finally, there is going to be, and we're already seeing our hospitals filling up, not with COVID patients, but with patients who have more chronic medical conditions that have gotten more serious because they weren't attended to during the pandemic. But to end on a positive note, even though the next pandemic is not going to be 100 years away, we all know that, we will come out of this one much, much stronger. We will have learned a lot as a country, as a region, as a state. We will be better positioned, and I will forever be hopeful regarding the resilience of our population. So thank you for your attention. And I am now pleased to really be able to introduce the keynote speaker, Dr. Rachel Greenup, who's an associate professor of surgery at Yale School of Medicine, chief of breast surgical oncology. She provides coordinated state-of-the-art care to patients with benign and malignant diseases of the breast as part of the Breast Center at Smilow Cancer Hospital at Yale New Haven. Prior to joining Yale, Dr. Greenup was an associate professor of surgery and population health sciences. Those words are dear to my heart, at the Duke University School of Medicine and Duke Cancer Institute, where she founded the Duke Breast Cancer Outcomes Research Group and was core faculty for the Duke Margolis Center for Health Policy. In 2016, she received the National Institute of Health Building Interdisciplinary Research Careers in Women's Health Award. That doesn't have any algorithm or eponym, I think, that I could label it, a lot of words, but very worthy to evaluate how financial cost and burden relate to preference-sensitive decisions for breast cancer surgery. In 2017, she was named the American College of Surgeons and American Society of Breast Surgeons Health Policy Scholar. Her research focuses on aligning patient-centered care with high-quality, lower-cost treatment. She serves on several national committees, and I'm delighted to welcome her to this conference today. Thank you.
Thank you, everyone, for having me. And although we're not together in person, it's a wonderful forum to share what we know and learn together. I'm going to take a minute to pull up my slides and assume that everyone can see that. So I'm going to be talking this morning about financial toxicity and the costs of breast cancer care. I have no disclosures. As many of you know, breast cancer remains a major medical and public health issue in the United States, with 1 in 8 women being diagnosed during her lifetime. And part of why we love taking care of breast cancer patients is that breast cancer care has always been on the forefront of incorporating evidence into practice, foregoing treatment that lacks benefit, and thinking about thoughtfully improving our patient experience along the way. Breast cancer surgeons have always thought about reducing unnecessary treatment that causes patient harm. We stopped performing radical mastectomies when it became clear that lumpectomy followed by radiation was equally effective. We have increasingly reduced our rates of axillary lymph node dissection, which causes lymphedema for so many women, as we've learned that small amounts of nodal burden can be effectively treated with radiotherapy. We've also acknowledged that for older women with very favorable breast cancers, omission of radiation is safe and does not impact survival. And lastly, we have identified a cohort of women with low-grade, low-risk ductal carcinoma in situ that may be able to safely forego standard surgery and radiation treatment. In 2008, Berwick and colleagues outlined the triple aim as their vision to align the health of the population, per capita cost, and patient experience of care. And you can see that blue dot in the center is really the sweet spot where there's a win-win aligning these 3 missions. In 1999, the Institute of Medicine charged the US healthcare system with improving the quality of cancer care across the country. And this included improved clinical care, the incorporation of evidence into practice, the importance of data capturing and monitoring, development of quality measures, improving access to care for our cancer patients, improving the affordability of care both for our health system and patients themselves, and providing better end-of-life care. The term value was first introduced into the literature in 2010 by Michael Porter, and this is defined as quality over cost or health outcomes achieved per dollar spent. Sadly, the US health system is the most complicated and expensive health system in the world. And we know by 2020, breast cancer costs alone estimated about $20 billion. Overall, healthcare costs have continued to rise in the United States, and despite incredible innovation, we know that 20% of our GDP is estimated to go towards healthcare. You can see on this graph that US healthcare costs are disproportionately high compared to other industrialized countries, and this does not always translate into better improvements in our population's health. There is an estimated $700 billion of waste per year in American healthcare, and much of this is attributed to unnecessary services, excessive administrative costs, inefficiently delivered services, prices that are just too high, fraud and misprevention opportunities. And by comparison, our estimated annual costs on public school education are about $625 billion per year. We also know that improved breast cancer survivorship, not only treatment, has resulted in higher healthcare costs. And we performed a SEER Medicare analysis looking from 1997 to 2013. This is women 65 years older after diagnosis of breast cancer who were receiving Medicare for healthcare. We categorize women based on the year of diagnosis. We propensity match them, which essentially helps us make sure that costs were attributed to breast cancer alone and not underlying baseline issues. And we compare costs between women with breast cancer versus those who were unaffected. We can see that age at diagnosis has been consistent over time, but there is a significant proportion of women in upper ages. About 15% of patients in our study were over 85 after breast cancer diagnosis, and we know that comorbidities were increasing over time. So our breast cancer patients are living longer and actually have more acute and long-term medical issues when compared to women of the past. Not surprisingly, compared to unaffected patients, women with breast cancer had worse survival and costs were higher. And so when we think about breast cancer survivorship, we have to wonder how improved survival results in higher costs for our patients and the health system. We found that per person cost differed by about $10,000 per person in women with breast cancer compared to matched controls, and that costs increased over time and correlated with stage. And this estimates to be about over $1 billion in additional Medicare costs over the next 15 years. And so we know that the oncology community needs to prepare fiscally and from a workforce standpoint to support our breast cancer survivors. Much of my prior work has looked at value in breast cancer and revolved around the idea of incorporating evidence-based practice and a natural reduction in costs for the health system and patients themselves. We demonstrated that treating women according to the ACAZOXY 11 trial resulted in fewer lymph node dissections, reduced costs for patients, and has an outcome important in patients of lower rates of lymphedema. We also showed that eliminating unnecessary surgery after lumpectomy by adhering to our national guidelines resulted in $31 million of savings per year. That shorter radiation that's equally effective also reduced about $164 million of savings per year for Medicare patients. And lastly, we did a nice study in conjunction with our GYN oncology colleagues at Duke showing that if women have BRCA mutations and ovarian cancer, bilateral mastectomy within 5 years of ovarian cancer treatment was not cost effective and did not help women live longer. So another opportunity to reduce unnecessary treatment and harm. There have been efforts to engage cancer providers, including physicians and APPs, to improve the value in cancer care. And the most notable example of this is the Choosing Wisely initiative that exists across multiple subspecialties in medicine, but in cancer care really targets avoiding waste. Examples of this include don't perform PET CT or staging in the setting of early stage breast cancer. We are unlikely to find meaningful radiographic or imaging findings that change our cancer treatment plans, and actually more likely to put patients through additional imaging and or biopsies that are not helpful. The other piece is that there's a recommendation to not routinely use white cell stimulating factors for primary prevention of febrile neutropenia. Apologies there. In all cancer patients, this is another example of reducing waste. We know that in oncology, concordance ranges from 40 to 95% in cancer patients. And that when we adhere to these choosing wisely guidelines, there's an association with reduced healthcare and healthcare savings. When doctors and APPs or oncology providers engage in continued medical education, this correlates with improved adherence to choosing wisely and can further reduce healthcare waste. But I really want to move towards how all this spending affects our patients and their families. Currently, about 37% of US families report financial distress related to medical care. As outlined in these data from the Center for American Progress, we know that national healthcare spending has exceeded the rate of growth in GDP and wages. You can see that between 1960 to 2010, wages increased only 16%, while healthcare spending increased over 800%. And so it's not surprising that our patients and their families are struggling to afford their healthcare. We are currently in a healthcare crisis. We have about 28 million patients who are uninsured, and there are socioeconomic disparities with greater rates of uninsurance among Latinos and Blacks. And this data does not account for increasing rates of uninsurance after the COVID-19 pandemic. There is high cost sharing, meaning that care is unaffordable. We are having more of healthcare spending shifted to patients and their families to pay for. And there's a rise in high deductible insurance plans, which is great for healthy patients. But when people get sick, it can lead to delays in or omission of preventive care and treatment services. And so my passion really revolves around financial toxicity. This term was first introduced in 2013 to describe the emotional and psychosocial distress related to the burden of unaffordable cancer care. The National Cancer Institute has introduced a conceptual framework that pulls together all the different factors that can lead to unaffordable cancer treatment. This includes pre-illness health, assets, debt, and income, illness and or injury, which for our oncology patients is their cancer diagnosis, medical insurance treatment choice, medical costs, non-medical costs, which we'll get into later in our session, resulting in financial strain, distress, health outcomes, and the risk of formal bankruptcy. The financial cost and burden of care can be categorized as direct payments, indirect payments, and hidden costs. Direct healthcare payments describe out-of-pocket expenditures for our patients and their families. These include things like deductibles and co-payments, prescription drugs. Indirect lost productivity costs describe employment disruption and or lost wages. And hidden costs describe aspects of care that are not supported by insurance or the health system, and things like travel, lodging, and childcare. Financial toxicity has also been shown across cancer types. We know that 40% of insured colorectal patients report difficulty in affording their deductibles. Up to 25% of cancer survivors report using most of their savings to pay for care. Financial burden is associated with poor mental and physical health. Blacks are disproportionately at risk of financial harm, and there is a twofold increased risk of bankruptcy after cancer. Our highest risk populations are our most vulnerable populations. These include younger patients who are not Medicare eligible, so they pay for private health insurance, those with lower socioeconomic status, minority race or ethnicity. When people are in a shorter time frame from their diagnosis, they've not yet had a chance to catch up on their payments, and advanced stage cancer patients who require more comprehensive treatment. Notably, financial hardship occurs both during treatment and also extends into the survivorship phase. There's the reported concern about paying for deductibles and using savings. When cancer survivors have to spend over 30% of their income, they're at a greater risk of financial hardship, but all cancer survivors, about a third, reported some financial difficulty related to their cancer care. And this graph shows on the right what I previously described, that our younger patients who are uninsured or have public Medicaid or any private insurance are at significantly higher risk than Medicare covered individuals 65 or over. We also know that financial hardship differs by race. This is a lovely study done by my friend and collaborator, Dr. Stephanie Wheeler at UNC, using the Carolina breast cancer study, and they surveyed over 2,500 women after breast cancer and purposefully sampled an equal number of Black versus white women. And you can see, after adjusting for age, stage, and treatment, overwhelmingly Black women were more likely to report any negative financial impact, a decrease in their personal or family household income, financial and transportation barriers to care, a greater risk of losing their job as a result of cancer treatment, and a loss of insurance. In a national survey of metastatic breast cancer patients, we saw that financial hardship was associated with treatment non-adherence or refusal. And when we interviewed women across different races and ethnicity, Black women were far more likely to stop or refuse treatment when things were unaffordable, where white women did things like skipping vacations or borrowing from friends or using savings. They had different financial coping strategies, but were more likely to continue with care. In the same cohort, about 62% of these metastatic breast cancer patients reported that they stopped working altogether. And women of color, again, were more likely to stop working, reduce their work hours, or change jobs, while white women were more likely to have the luxury or privilege of retirement. I think financial toxicity was acknowledged as a quality of life issue until Scott Ramsey published the landmark study in 2016 that when you have cancer and you become bankrupt, you are more likely to have early mortality. And this is when it really caught the attention of the community that unaffordable cancer care was a survival predictor. They used SEER registry data from the state of Washington that they linked to regional bankruptcy claims, and they propensity matched, again, cancer patients who declared bankruptcy to no bankruptcy to control for other potential biases. Overall, across cancer types, bankruptcy was associated with a greater risk of death. And in our breast cancer patients, women with breast cancer who went on to bankruptcy were 1.5 times more likely to die. In this high-risk cohort, rates of bankruptcy increased over time from diagnosis and was more likely in women with metastatic or distant disease, and again, correlated with survival. As part of our American Society of Clinical Oncology efforts to address the high cost of cancer care, in 2008, there were guidelines put forward that cost discussions should be had with patients embarking on treatment. We know that when cost discussions occur, they result in cost reducing strategies. Patients and providers become creative in ways to reduce expenditures for individuals receiving care, things like having an MRI at an offsite facility with lower facility fees, or prescribing generic medication, or having procedures within a calendar year prior to resetting of deductible. And it does include costs in treatment decisions. It can help with financial preparedness, and it can result in patient and provider awareness, education, and activation. Much of my work has looked at how costs impact decisions for breast cancer surgery. So eligible women with early stage breast cancer can choose between lumpectomy followed by radiation or mastectomy, and many women are continuing to choose double mastectomy with the removal of the unaffected breast. We have long-term and contemporary data consistently showing that for eligible patients, these two treatment options are equally effective, and they result in comparable local recurrence rates and equal overall survival. And so in the setting of early stage breast cancer, surgical treatment choice is really preference sensitive, meaning that women weigh the pros and cons of different options and make a shared decision with their cancer treatment surgeon about what treatment works best for them. When women come to see me in the clinic, they have a large multidisciplinary team. They often bring friends and family, and we talk about the different factors of each surgical treatment option, including things like recovery time, risk of recurrence, peace of mind, which my patients tell me often is the driver behind them choosing bilateral or double mastectomy. We talk about the side effects and complications of each surgery, the need for surveillance, and the long-term anticipated appearance or aesthetics of each option. But we rarely talk about costs. So we embarked on a survey of breast cancer survivors. This was a survey developed with input from our patient advocates through the Alliance Foundation. We pre-tested this in volunteers, and then we partnered with the Dr. Susan Love Army of Women and the Sisters Network, patient advocate and coalitions that include breast cancer patients and survivors. Our final cohort was over 600 patients. They were on the younger side with a mean age of 58 years. They had early stage breast cancer. They were on average about 7 years from diagnosis, though we had some women quite far out from treatment and diagnosis. They were overwhelmingly privately insured, although some were Medicare covered, and they had a higher household income when compared to the general population. When we asked patients or survivors how important were costs when making their surgical decisions, 71% said they did not think about it. And this is understandable. This is a highly stressful time when women are facing a potentially life-threatening diagnosis. And so many of them don't think about money. They want the best treatment at all costs. But about a third said they did think about costs. They were considering it when making treatment decisions. Overall, the two most important factors of surgical decision-making were that women said opinions and advice from the medical team or what their doctor recommended was the number one factor that impacted their decision-making. And number two, the fear of recurrence, which is very understandable. And you can see in the cohort overall, cost of treatment was relatively unimportant compared to these other issues. But when we looked at women who had household incomes $45,000 or less per year, they still prioritized recommendations from the medical team or fear of recurrence, but costs of treatment became significantly more important. And among this population of lower income women, they prioritize costs of therapy even over the appearance of the breast or keeping their breasts. And we still aren't talking about it. About 80% of our population said they preferred to know the out-of-pocket costs before they started treatment. 40% believe that doctors should be thinking about out-of-pocket costs as we made a recommendation for their cancer treatment. And about 35% of patients reported somewhat to catastrophic financial hardship. And this is a disproportionately well-insured higher income population when compared to the US. Looking at personal and financial costs in a more granular way, we also asked women questions about how breast cancer surgical treatment impacted their personal lives. And you can see that bilateral mastectomy patients reported a greater risk of employment disruption, difficulty paying for care, and cancer care-induced financial hardship when compared to women who underwent lumpectomy. We also found that 78% never discussed costs with their cancer team. 35% reported that costs were much higher than they had expected. The median reported out-of-pocket cost for our survey participants was $4,000, but 5% reported paying over $40,000 out of pocket towards cancer treatment. And again, higher out-of-pocket costs were associated with bilateral mastectomy, receipt of chemotherapy, and breast reconstruction. And this is essentially reflecting that more comprehensive multimodal therapy that often extends beyond 1 calendar year, which requires resetting of that deductible a second time, leads to a greater risk of financial hardship. Other really important findings from our study that came up in our open-ended qualitative analysis was that women talked about being self-employed and not having insurance as a major barrier. Folks borrowed from family and friends, they fundraised. Really savvy participants talked about negotiating with hospitals, refusing to pay or agreeing on a monthly payment plan. Folks relied on financial assistance programs or grants to help support their cancer treatment costs. There was a lot of report about difficulty navigating the system, even among those women who were insured. It was a huge mental and emotional burden for them to have to make phone calls and navigate their insurance program. There was a really touching finding that many women who did not have financial burden had a huge awareness that other women did, and some kind of survivor guilt around that. And there was commentary about changing the trajectory of their careers. Some of the most powerful findings of our study were in women's own words, and women talked about direct costs. That one woman said 15 years of savings was completely depleted in 24 months. I never in my life thought I would spend the entire thing on paying for cancer bills. Another comment was, I lost my job when I began treatments and have been unemployed or underemployed ever since. There was commentary about the burden of hidden costs: food, gas, transportation, parking, mastectomy bras, non-healing infection. The non-medical costs were so high. And there was commentary about cost transparency or communication. One woman said, none of my docs, who I all considered very good in other ways, ever mentioned costs. And another said, I found the unexpected cost to be most difficult to budget for. Without warning, it was financially tough every time. And this is a word cloud of the open-ended responses. And you can see that insurance, cost, payment, cancer treatment really rose to the forefront. Moving forward, shifting gears a little on evaluation of the medical panel expenditure among breast cancer survivors, we know that financial hardship does lead to long-term quality of life issues. This study was published in Cancer in 2015 and looked at almost 20 million cancer survivors. And when patients reported financial burden, they talked about borrowing money, declaring bankruptcy, concern over paying large medical bills, and inability to cover the cost of their care. And notably, about 1/3 reported this, and it was clearly associated with poor mental and physical health, depressed mood, and overall worry. In another study using the same survey, the Medical Expenditure Panel Survey, this was a stratified self-reportive expenditures by age. And we know that overall cancer survivors with higher reported healthcare expenditures had reduced productivity at work and at home. So how are physicians considering and communicating costs? And this was the second piece of my NIH-funded grant. We know, backing up, that cost communication is rare in clinical oncology. About a decade after the American Society of Clinical Oncology guidelines were put forward, it's still very uncommon. We know that patients now desire cost transparency and communication. It can lead to cost-reducing strategies, and that oncologists influence patient choice for treatment. On several surveys of practicing oncologists, we have found that oncologists generally overestimate how cost aware they are. So we as cancer providers perceive or overestimate how much we're thinking about and discussing costs. We do report that drug costs can influence treatment recommendation. Oncologists desire freedom to determine value of cancer therapies, so they don't want mandates placed upon them. And we do report, sadly, that reimbursement can influence practice. And in a fee-for-service model where doing more care results in higher RVUs and reimbursement, this can be a conflict of interest. We know that oncologists are key stakeholders in the cost of oncology care. And the most striking finding was that many physicians believed we should not discuss costs at all, that it was truly unethical to think about money when we were making treatment recommendations for our patients. And this has been a historic kind of sacred relationship that we're impressed upon us to provide care for the patient at all costs. But now with cost sharing and cost shifting, we probably need to readdress how we consider costs for our patients. So when we surveyed breast cancer surgeons, about half believe that doctors should be thinking about patient costs. About half believe that we should think about cost to society when making recommendations for individual patients. And about 38% believe that if we were facing two treatments that were equally effective, we should lean towards the least expensive one. Overwhelmingly, 87% of breast cancer surgeons believe that patients should have access to the cost of their cancer treatment before making treatment decisions. But on the survey, our surgeons, so this was a survey from the American Society of Breast Surgeons, surgeons generally underestimated the importance of costs on women's treatment decisions. We believe that risk of surgery, appearance of the breast, and risk of recurrence were the most important factors driving breast cancer surgery. And only 6% of surgeons believe that costs mattered to patients. And this differed in the prior data that I reported, where a significant number of women were thinking about or wanting access to the cost of their cancer treatment. Surgeons reported major barriers to cost communication. They believed that they didn't know enough about costs and lacked resources to provide accurate, good information. And I think that remains very true. Many believe that they had an inability to help. So discussing costs was difficult for them when they couldn't do anything about it. Time was a major issue. So in a busy clinical practice, having cost discussions with patients can be really difficult for faculty or physicians. And 1 in 5 believe that discussing costs might negatively impact care for women. Maybe knowing how much cancer treatment costs would shy some women away from receiving treatment at all. What can we do in the oncology world? I think it's really important as we think about providing cancer care moving forward, that we address financial well-being as part of a patient's social history. When we meet patients for the first time, we ask about whether they smoke, whether they use alcohol, what they do for work, who they live with. And if we normalize financial well-being as part of the social history for all patients, we will destigmatize this belief that discussing costs is a negative aspect of cancer care. We should talk about affordability of care. I similarly think it's very reasonable to ask all patients, do you have any concerns about affording your medical care? And I really believe that patients should ask their doctors, can we discuss the cost of my cancer care? If physicians can't help or are ill-equipped to have those discussions, most health systems have social workers and or financial navigators that can actually help patients work on better understanding their insurance coverage and prepare them for anticipated treatment expenditures. There is a formal screening with the Cost Facet tool. This is a tool developed and validated by the University of Chicago. It's 11 items. It's not extensive, but it addresses things about money and savings, out-of-pocket medical expenditures, and expected medical expenditures, worry about financial problems, a choice about financial expenditures, feeling frustrated, being satisfied with your current financial situation, ability to meet monthly expenses such as rent, food, mortgage, transportation, financial stress, and the degree to which that contributes to a patient's cancer experience, job security, and feeling in control. In conclusion, as we think about the proposed metrics for high quality healthcare, we talk about life expectancy, overall well-being, obesity, healthy communities, care access, patient safety, evidence-based care, patient-centered care that matches patient goals, and personal spending burden and population spending burden have now been included in updated potential quality measures that really will make our country healthy overall. I think in summary, we know that financial cost and burden is a major issue for our breast cancer patients. It is a potential risk for all women, and despite having populations that are at higher risk, about 50% of women are at risk regardless of their ability to pay, their socioeconomic security, their job security. We know that financial cost and burden really matters to patients, and that it has potential to impact their cancer treatment decisions. And I fundamentally believe that addressing financial hardship and burden is critical to patient-centered breast cancer care. I have many people to thank for this work, most importantly, the women that participated in my survey and my studies. And I thank you all for the opportunity to join you today, and I'll be happy to take any questions.
Thank you, Dr. Greenup, for that wonderful presentation. I think that resonates with many of us, whether professionally or personally. So thank you for that. We'll take questions for anyone that has one. Please type it into the chat box. I'm curious, in your own institution, Dr. Greenup, if you feel like many of your colleagues feel similarly to you, that is it a regular discussion in that first visit that you have with new cancer patients amongst your colleagues as well?
Yeah, so it's a great question. Duke School of Medicine really has a kind of critical mass of researchers studying financial toxicity, people like Yusuf Zafar, Peter Yuval, myself. And then across the street is UNC, Stephanie Wheeler, Katie Reeder-Hayes. So we have a lot of folks that have kind of regionally band together to address this issue. When I moved to Yale 7 months ago, we're starting to more socialize this. I think one of the wonderful aspects of Yale School of Medicine is that it provides care to an incredibly diverse population in the greater New Haven area. And many of our patients are socioeconomically disadvantaged and or uninsured. So the system has already established support measures for individuals who aren't able to pay. I think one of the most surprising pieces of my work has been that you can't really tell who's struggling financially to afford their cancer care, and that nobody's immune. So having discussions with all patients really is a way to normalize, socialize, and provide potential resources regardless of individual socioeconomic standing.
And there are some questions. Someone had commented, you compared bilateral versus lumpectomy, but what about one-sided mastectomy versus lumpectomy?
Yeah, so that's a great question. Unilateral mastectomy compared to lumpectomy did not show a significant difference. When we introduced reconstruction, which is such an important piece of care for so many women with breast cancer, but also is associated with multiple procedures often and care that can extend over that first calendar year. It's unilateral mastectomy with reconstruction did show to be a little higher risk than lumpectomy.
And Dr. Holcomb had said, as a physician, we are often unaware of the specifics of costs related to treatment, since different insurance coverage have markedly different copays, et cetera. Can you comment on the need for centers/hospitals or practices to provide access to a financial navigator?
Yeah, I think that's really the most important piece. When ASCO originally recommended that physicians should be talking about affordability of care with patients, the recommendation was never that physicians or providers should be navigating cancer patients through the affordability of care. I think we don't have the data. It is so complicated, nuanced, and truly opaque. But we do know that the doctor-patient relationship is very powerful, and bringing it up and normalizing it can help patients get access to the resources they need. So I would say many health systems across the country are really working in some capacity to have financial navigation. Sometimes that is really an individual with an official title of financial navigation. We were really privileged at Duke to have a true financial navigator embedded into every clinic and the outpatient setting. Sometimes it's through social work that can then connect the dots between the billing folks and outside resources such as local or national philanthropy. There's wonderful resources both in North Carolina and Connecticut, such as the Pretty in Pink Foundation, Infinite Strength, and then the Patient Advocate Foundation nationally provides both case management and grant support if individuals cannot afford medical treatment, including cancer care.
There's another question. What is the best source for clinic staff to get financial information? I struggle as a nurse in my clinic in this topic, as I don't know where to start with a solution to this conversation.
Yeah, again, so there is an effort from CMS to have price transparency, and a lot of health systems will have that published online. Even when you go onto the CMS website and you review the Microsoft Excel spreadsheet of all the cost information, it's challenging in that it is not personalized to the patients in front of you. The patient in front of you may, even if they have the same insurance plan, their out-of-pocket payment may differ dramatically. You can contact your hospital billing folks, and they can often give you some estimate of what the expected payment is. Certainly in my world, to book a patient for surgery, the hospital has that information. But generally at time zero, out-of-pocket costs are going to be similar for cancer patients. Once you have a cancer diagnosis, most individuals, about 85%, the data show, meets their deductible within the first month or two, with diagnostic testing and initial steps of therapy. I think the big message for folks is that individuals going back for second surgery, individuals having surgery, chemo, radiation, reconstruction, individuals whose care extends beyond 1 calendar year, or those with living with stage 4 cancer, really need to be on our radars in terms of folks that might need to be connected with social work or financial navigators to address this aspect of treatment.
And there's another question. Is mastectomy less expensive than lumpectomy and radiation, which is less invasive?
So a unilateral mastectomy without reconstruction, my survey data showed that women had the lowest out-of-pocket payments because you have one surgery. You typically don't need radiation. It's a shorter course of treatment. Lumpectomy with radiation was the next highest, and then double mastectomy with reconstruction was the most expensive for patients.
And I'm just curious, where do you personally see future research in this area going or heading towards?
So we, some of the truth about being a surgeon scientist is that some of what you learn is when things don't work. And we're in the process of writing these data up, but we, prior to the pandemic, had recruited about 15 patients where they received cost estimates based on surgical treatment choice. And overwhelmingly, women said they couldn't process that information that early. They were too afraid, understandably, of a life-threatening diagnosis. They were facing a series of very complex treatment decisions. They were going to appointments for staging, for port placement. And so thinking about money in advance of treatment decisions was really not the right time. That has really refocused me or pivoted me to think more about providing cost information and or patient narratives to help women know that even if they don't want to think about it at diagnosis, they should continue to think about it through treatment. It's the patients that are unexpectedly hit with high cancer treatment bills that are at greatest risk. And so I think we as a health system and patients, as we increase awareness and increase activation, we can hopefully do a better job preparing patients and their families.
Thank you. Are there any additional questions? I'll give it one more minute. Okay, I'm not seeing any additional questions. Thank you so much, Dr. Greenup. Thank you for all joining us today. And we hope to see you in one of our next sessions.
Okay, thank you so much for having me.